get started. First, I would like to introduce Dr. Joshua Kreiss. Thank you for coming.
Yeah, can I put this here?
Dr. Kreiss is a neurologist and a physician coach who helps individuals and families navigate care in the healthcare system. We also have Dr. Mindy Lockskin, who has been so faithfully working out these tech issues, who you know as our founding chair, and also our facilitator for today.
Great. Do you want me to use the microphone too?
Both.
Both?
Yeah,
Okay, good.
This makes it loud enough for the room. This makes it so it's recorded.
Excellent. Okay, good. Great. I have about a half an hour. Can everyone sit through a... Oh, we'll see. Maybe it'll be less. Can you hear me okay with this?
Yes.
Okay. Is that better? Okay, good. Anyone not hear me? Everyone's okay. Good. Excellent. Yeah. Well, so thanks for coming. The title of my talk is Advocacy in Action: Your Voice in Healthcare. And as I said, my name is Josh Kreiss. I'm a practicing neurologist in Truckee, California, and also a board-certified patient advocate and a professional life coach. There's more on my background at Growing Spaces Coaching, which I think is listed there on your handout. It's truly an honor and a privilege to do what I do. I love it, and it's an honor to be invited to talk with you here today. I really just have one goal for today. It's to offer you a practical guide on being heard. So being heard, it's the key to feeling better about living with Parkinson's disease, to getting answers, to building a better care team. We're all too familiar with this situation. You've waited for 3 months for this doctor's visit. Your family and you had a really terrible week. You're finally getting into the room. Your heart's racing. You might even be a little bit sweaty. You have lots of questions. The doctor or nurse practitioner comes in and is clearly looks rushed, and you're wondering, will we even leave here with any answers that make life easier? If that feels familiar to you, you're not alone. You feel very alone, but trust me, you're not alone. It's hard because Parkinson's affects so much more than movement. It affects the entire emotional landscape of the family. Identity, relationships, routines, and much, much more. I don't have to tell you people. Is there an aspect of life that's not affected? We know that we can't control everything about the disease, but, and I know this to be true, you can become much more skilled in how you navigate it. Today's not about blaming doctors or blaming the system. It's about something much more useful. Practical skills to help you become a better advocate. So you have better care, better communication, and better outcomes, with less stress and a stronger sense of purpose. So whether you are living with Parkinson's, living with another neurological condition, or caring for someone you love, this applies to you. Advocacy, kind of a big word, so what does it mean anyway? And let's be honest here, when things don't go well in healthcare, probably when things don't go well in any aspect of life, we get frustrated. Sometimes we get angry, and sometimes we should. But advocacy is not about being difficult. Advocacy is about helping your doctor to see the full picture, making visits more useful, protecting safety, and making sure your voice matters, making sure that you're heard. So let me ask you something. How many of you have left an appointment thinking, oh, I wish I had said that thing, or I wish I had asked that other thing? Any hands? Yeah, most if not all of you, right? And you're in good company because we're all human. We think of the perfect question in the car on the way home. If there were an Olympic event and thinking of questions too late, we'd all get a medal. I'll be driving back to Truckee this afternoon, and I'll be kicking myself remembering of things that I forgot to share with you today. We're all the same. Well, here's the good news. You may not be able to control everything about Parkinson's or another neurological condition, but you can get better at navigating care. And if you want better answers, what do you need? You need better questions. So today, we're going to talk through 10 simple questions. You have those questions in front of you. This is not a lecture. I very much want this to become a conversation. Do you guys want to hold questions towards the end, or is it okay if they ask me questions?
Whenever you want, and I'll run around.
Okay, great. Okay, so really, feel free to interrupt me and ask me questions. Just raise your hand, and we'll come over with a microphone. Jump in any time. Or write down your questions or your ideas right there on the handout. And even feel free to share what's worked for you as they come up. You know, I'd love to hear them. I'm sure others here in the room would love to hear them too. Sound good?
Yeah.
Sure.
Great. So let's go. Here's the first question. So do this before you walk into that dreaded doctor's visit, right? Ask what are the 2 or 3 most important things we need from this visit? Like, what matters most today, right? What is having the biggest impact on daily life? And also, like, what might be able to wait until the next visit? But watch out here, because if you don't set the agenda, the visit will. Number 2, how can I help my doctor understand what's really happening at home? So remember, you live the full story. Your doctor only sees a small snapshot, one slice through the apple. So keep a simple log. Write a short story. Send a note ahead if possible. Doctors actually love them, even if they don't say it. In fact, it makes the doctor's job easier. And I don't know if you know, but that written note that you get in front of the doctor before the visit, or even during the visit, it can be scanned directly into the electronic medical record. And that's pretty nifty, right?
Yeah.
Your words can be incorporated in the medical record. Number 3, are you all following along there on the handout? That's all listed so you can bring it home too. How can your loved one be included most effectively? So the key idea here is that there's no perfect answer. It's very situational. Can I speak openly in front of my loved one? Yeah, in some situations that's perfectly appropriate. And conversely, what should I do if I have concerns that I don't want to raise in front of them? I don't want to embarrass my spouse, right? I don't want to set them off, right? How do I handle that? Well, trust your instincts here. Really listen to your gut and communicate with the doctor and her staff before the visit. And then they'll give you a sense of that, and you'll do the right thing. Number 4, how do we make the most of short appointments and not suffer the regret of it feeling too fast? Because often these appointments whiz by. I mean, if I'm given half an hour to see a patient as a follow-up, I better be done in like 17 minutes if I'm going to have time to do the documentation, make a couple calls, whatever I need to do to help that patient. 17 minutes, is that enough for what happened, for you and your family over the last weeks and months? Probably not. So, if we all know this feeling, it's gone by too fast, and so what do we do to not suffer this frustration? Bringing a medication list, or at least reviewing the medications before the clinician comes in the room, writing your questions down. I think we all know that, right? And track changes between the visits. Like, you can even include these changes in your written summary, right, that you deliver to the staff before the meeting. But probably, here's the most important tip. Take notes, and even ask to record the visit, right? So you can refer back to it later. how can you expect yourself to remember everything? I mean, really, right? Like everything, this is a stressed moment. There's lots of information. There might be new information. There might be disruptions in the room. How can you expect yourself to incorporate all that information, really? So, in addition to the recording, like, ask your doctor for the after-visit summary. Okay, the after-visit summary is, for those of you who don't know, is a short document available at checkout and has all your doctor's recommendations in place, in one place. So how could you possibly leave without this really valuable, well-communicated information? It's a mistake to leave without it. And one more thing, more ears is good. Can family members join a visit remotely? Yes, definitely they can. Just ask first. You might really benefit from that outside perspective, that critical distance of, your sister who lives on the East Coast, or, it's just really nice to get another set of ears there. Number 5 is, what's the best way to get answers between visits? Because we all know life doesn't wait the 3 weeks or maybe the 5 months for that next visit, does it? Lots happens. And the key idea here is to learn the system and how the system works before you need it. So learn how to use the patient portal. There's probably an 800 number, or a very accessible number that the health system, the hospital, the clinic you go to has, and there's very helpful educators that are available to show you how to use the portal. The health, trust me here, the health system really wants you to use the patient portal. It saves them time and money. And know when to call and what you need to do to develop a confidence about this. Ask your doctor. Like, you can't, if you ask your doctor questions in advance, you can't get it wrong. When do you want to hear from us? What situations or what symptoms should prompt a call to you? If you ask your doctor, there's not going to be any ambiguity about when you call. And there shouldn't be any emotion around it either, because you've asked in advance, right? And as possible, also know what's urgent. Again, use your doctor as teacher. Like, what's going to require a trip to the emergency room to urgent care? Again, there doesn't need to be emotion around that, right? It's just then you know what to do. And maybe favor emergency rooms to urgent care centers. Urgent care centers can be helpful for a lot of common things, but you're going to get definitive care in an emergency room. But again, gauging that, your doctor is your friend, your advocate, and the person can help you to understand that for the particulars of your situation. But if you find yourself in a situation, say at home, and you're scared and you still don't have answers, like that's the time to to go get the help you need in the ER. So, how do you get the right people talking to each other? And let me stop here and just see if anyone has any questions. Go ahead.
I just saw my new neurologist, and my husband and I came home, and I thought to myself, how do I get all my doctors together in one room so they can hash it out? Oh, don't take this. No, this is bad for you. No, I don't have time to spend 6 months going to all these different appointments and listening to everything.
Right.
I just can't do it.
Yeah, definitely.
The question is, how do we get our team together?
Yes, team.
Exactly. So this is great. So number 6 answers that to the best of my abilities. And the most important thing that I have to say here to answer your question is you need to demand it, because there is nothing more important, and it doesn't happen enough. Okay? I would say this is probably the second most important question. Go ahead.
Does it happen at all?
Does it happen at all? It happens if you have a very committed clinician who knows the benefit of that, both for his or her practice, and knows how that's going to benefit you, and is also willing to take the time to do that, because It does happen, but it doesn't happen in every instance, and there's also no financial incentive to do that. Yep.
Does the medical profession use Teams or Zoom or anything along those lines? Are they willing to build an appointment into your schedule? And if so, does the insurance company cover something like that?
Yeah, so so the specifics of that I'm going to defer to Steve Phillips, who will speak later, because I think you're really an expert in those areas. The short answer is yes, and I would say in my practice anyway, I do use Zoom and there are different reimbursements for that. And Teams is largely used administratively. I also have an administrative role, and so isn't that interesting that the clinicians aren't using Teams to talk to each other? It's the administrators. What's up with that? Yes. That doesn't make sense, does it? Right? Yeah.
Any questions on Zoom?
Yeah, that's coming up too. I'm going to talk about that in just a minute. But on Zoom, on these guys' Zoom, yeah. See? Okay, great. Yeah, go ahead.
Not yet.
Not yet. Okay, fine.
One more.
One more? Oh, go ahead, please.
This is a very unusual question. I am widowed twice. I have no caregiver. I've had Parkinson's now going on 4 years. I've been doing it myself. I do not have a caregiver, and I don't know how to get one. Can you help me?
I could help you, and I think that we could talk afterwards about that. There are a number of different possibilities, but I would need to know more about your situation. And I think that there are a number of people in this room who could help you think about that too. That's a really important question. And to go it alone, that's hard, as you know all too well.
Oh, yeah.
Yeah. But, back to this question on collaboration, I really think that collaboration is the magic, okay? What do we say, like, teamwork is the dream work? It's a catchy phrase, right? But it's really true, right? So if you have a primary care provider, you have multiple specialists, neurologists, gastroenterologists, cardiologists, right? And you have different therapists. You have a talk therapist, a physical therapist, a speech therapist. You might have an occupational therapist. The list is long, and yet no one's talking to each other, like, right? Like that doesn't work. And if we're going to find someone to be the glue, then it usually falls to a family caretaker, right? But we know, for those of us who have worked as family caretakers, how taxing that is, how exhausting that is, right? But if there can be that collaboration, there's really, it can be so powerful and so helpful, and the care that you will get will be superior. So back to your original question, demand it.
Okay.
Yeah, go ahead.
I mean, it's kind of lands on our responsibility to make sure that we tell our neurologist, I guess, or movement disorder specialist, we went to the endocrinologist and she's telling me this, whatever, this is going on, this is going on, this is going on. Because with your next one, your number 7, kind of falls into that it's not always Parkinson's, but I'm just saying that we have to be able to tell, if they're not going to communicate to each other, we've got to communicate it to them.
Well, you do. I mean, you can, if you're in a larger health system, there's an electronic medical record. Hopefully there's shared records. Most of us are on Epic now. I can see the notes by the endocrinologist. If your neurologist did, what your neurologist is supposed to do, he's reviewed the records of your other doctors before the visit, so there's some idea, of what's happened in these other visits. That doesn't always happen. It's really, provider dependent. And honestly, the doctor may not understand exactly what the endocrinologist is saying or what the implications are for you. So it's on you or on your family member, your caregiver to help advocate for you and make sure that neurologist knows that's happening. Do you have a hand up too, or did someone over? No. Okay.
I was going to add,
Yeah, go ahead.
as a family physician, unfortunately no longer practicing, that was my training, was to be the one. We always called ourselves the orchestra conductor, the one who knew all the specialists and kept track, knew who to refer somebody to, pick the good neurologist, not the neurologist who doesn't return our calls, let alone yours, things like that. So if you don't have a good primary care provider who is willing or able to take the time and pull together all those different reports from all the people you see and help you process and synthesize and make sure that the overlaps are appropriate, I suggest finding another primary care provider if you can.
Right.
That was one of my questions. So the primary care provider should be the team leader.
That's the dream.
Right. So how do we know what symptoms are attributable to the Parkinson's, to medications, to something else, right? This is really one of the hardest things. And sometimes doctors don't know either. We don't assume that everything is just Parkinson's. That's a mistake. Someone falls. Often multifactorial, fatigue, dizziness, confusion, big mood changes. It's not always clear what's causing what. So ask to be reevaluated, reexamined, get the attention that you need. And how do we speak up when something doesn't feel right? Like, this can be uncomfortable. You might think, oh, well, maybe I'm wrong, right? Or I really don't want to offend the doctor. But listen carefully. Being polite does not mean staying silent. You can say things like, I don't understand. Can you say that again? Please slow down. Can you explain that differently? I'm concerned or confused about this or that. Right? I mean, it's well within your rights to use these very common but useful statements. Respectful honesty helps everyone. If you remain silent, it really does not serve you. So there was were you asking just a minute ago about how we use telehealth and technology wisely? And telehealth certainly there's so many benefits. Access to specialists, saving on travel time, facilitating follow-up visits is a very short list of benefits of telehealth. But there are certainly situations where it's better to be examined in person, right? Or even just to have that human connection, right, that we lose when we're on a Zoom conference. But there are very many benefits to telehealth. I mean, really, I think that most important here is to use both thoughtfully. I think to have, if it's possible, have that first visit in person, so you know what your doctor smells like, and then you can move on from there. But that's not always possible if you're, I don't know, out in Elko or something, right? How do we? Number 10 is for me the very most important. How do we protect ourselves from burnout? Because caregiving is hard. Caregiving is very, very hard. And many caregivers quietly carry a lot, much more than the world sees. So let me ask, how many caregivers here feel like they're the one holding everything together? Yeah, that things are falling on your shoulders. Well, when you're in an airplane, they say, put your own oxygen mask on first. Right? Because a depleted caregiver cannot sustainably provide care. I think of it like a hub and a wheel, where the caregiver is supporting the entire care network. If the hub fails, the wheel collapses. And the entire care network collapsing is not good for anyone. But it's hard to do that, and I would say among my coaching and advocacy clients that the number one thing I see people doing is not getting the support, not getting the reprieve, not getting the breaks that they need to keep on keeping on.
The caregiver?
The caregiver.
Okay.
So in closing, you may not be able to control everything about Parkinson's or another neurological disease, but you can be better prepared. You can ask better questions. You can communicate more effectively. You can be heard. So I'll leave you with one last question, and I'd love to get a few answers on this. What's one thing you'll do differently at your next doctor's visit? Yeah.
I'm going to change doctors.
Okay. Awesome. Love it. Love it. Anyone else? Yeah, go ahead.
Take notes.
Yeah. Yeah. Yeah, most of us have a phone with us. Just say, hey, is it okay if I record this?
I like that.
Right? Yeah, it's so easy. Yeah. Yeah, go ahead.
I do a pretty good job of getting questions written down. But then he'll ask me, when did this particular symptom start? And when did this one stop or whatever? And I don't have a good timetable of my own symptoms. So I need to try and get better.
Right. Do you want to?
Yeah, so that was not necessarily having the timetable for the symptoms to bring that history of what's going on to your doctor's appointment.
Yeah, go ahead.
Well, I'm just a caregiver, but I'm curious.
Just a caregiver, huh?
But my question is on the people talking to each other.
Yeah.
Realistically, how can you request that from like a pharmacist talking to a therapist? I mean, can it?
Yeah, you just ask for it. You just hold them accountable. How do you get your accountant to finish his taxes? Right? Right? You just say, hey, will you please talk to the pharmacist? I'm concerned about this, and send me a MyChart message or whatever. You ask for it, and they didn't do it. You call them back and say, where's my answer? You said you would do that. How do you get your handyman to come over to fix your fridge that's dripping ice out of the front and ruining your wood floors?
Okay. Thank you.
Are there any programs that you could load stuff into, like, I'm going to say ChatGPT, but something like that, or what is it, Copilot? You can load a whole bunch of information in and have it summarized?
Any large language model would do that. Right? Claude and ChatGPT, or I'm trying to think of one that wouldn't. And then you could output that, or you could leave it there. There's so many different ones.
Is there one that's more medically or?
I don't know. Does anyone? I'm trying to think of one that wouldn't work for that purpose. I don't have a favorite.
I think ChatGPT has more medical experience so far. It's learning fast, but I think any of them can do it.
Yeah. If anyone has a favorite, let us know. I think they would all do that just fine. Go ahead.
How are you seeing AI affecting your practice?
Oh, yeah.
What do you see coming?
Oh, sure. He's asking. It's a great question. How do I see AI affecting my practice, and what do I see coming? It's a great, it's a really challenging, good question. I see it as a good thing and a bad thing. I know we want to let our next speaker come on, so I'll give you a short answer, but I'm happy to. I got time? Okay, great. I think it's a wonderful thing in terms of actually just doing, using it as a tool, like you say, to consolidate information. It helps me sometimes to think of possibilities that I haven't thought of. Oh, why isn't my patient responding to carbidopa, levodopa? Like, which one of the 4 Parkinsonian syndromes might this be? Like, did I forget the characteristics of, multisystem atrophy? Like, so in that sense, it's good. It's a little bit, if I'm reading your endocrinologist note and I'm like, what does it mean for the TSH to be elevated, but the T3 and the T4 to be low? This kind of thing where it's out of my field. It's useful for like a quick education, that kind of thing. I think that the downside is that there's the AI hallucination. So I've seen renderings where it says, oh, use an anticoagulant like Eliquis for sepsis. Okay, and so if you just take it at face value, you might hurt someone. Okay, and then also people come in like they're like overnight experts, and they come in and go, well, Dr. Kreiss, let me tell you, they're educating me about something which sometimes they are. Like sometimes I don't know that, right? But sometimes that's dangerous, right? Just like the Eliquis and the sepsis. So I would say use it as a first pass. Right, and don't rely on it as like definitive, ultimate information, right? But I think I don't know if it'll put me out of a job. It might put me out of a job where there's but it might not. I don't know. I mean, could someone without 10 years of education just sort of represent what the AI model is saying? I know there are medical schools who are training their residents on with AI and requiring that they use AI with every case. So that is AI is going to change everything. Yeah. Go ahead.
One hard question. When you go to the doctor, you've had Parkinson's for many years, and you see them time after time, and there's really nothing's changed, or maybe little things.
Yeah.
But what is the doctor thinking when he sees a patient like that? Has he seen you over and over again, month after month, or 6 months after 6 months? What is it you're looking for when I walk through the door?
Yeah, so I'm looking for changes. I'm looking to see if you're moving more slowly. I'm looking to see if you have, more or less of a tremor. I'm looking to see, the volume of your voice. I'm looking to see, again, like facial expression. I want to know if you've fallen. I want to know, I want to know about your ADLs, like, how you're going about your life, your instrumental ADLs, like, are you managing things, or are you just dexterous as you used to be, or is that getting in your way? So I'm following all that. Do I need to change your medications, right? Is it okay to be on the long-acting form of, the carbidopa, levodopa, or, would it be okay to be on the short-acting, or is that just too much work to, dose as frequently? It's that kind of thing, right? I'm wondering if you might, there's different forms of Parkinson's, not just Lewy body and Parkinson's with dementia, but is there a dementia phenomenon coming up? Are you getting depressed, right? Are you getting depressed because it's just dopamine? Dopamine doesn't just affect movement, right? Dopamine very much it's like our happy neurotransmitter, right? So those are the kind of things I'm looking for. But man, if you're going to your doctor, your neurologist time and time again, there's been no dose change, and you're kind of cruising, and you're just not that progressing that quickly, I don't know, spend your time and money elsewhere other than going to see that same neurologist, right? Yeah, does that answer your question? Okay, so just like some final pearls, unless anyone else has another question. You have a question, go ahead.
It's more of a story.
Oh yeah, go ahead.
My neurologist was in San Jose, and he had to shut his business down. Mm-hmm. So he emailed me all of his records on me. And so I went to see Dr. Trong, but before I did, I sent all those records to him ahead of time. He actually answered me back and said, thanks.
Okay.
That's the way it should be, right?
Yeah.
That's the way it should be.
Yeah, that's good. So just some final pearls. We had a question. Go ahead.
This is a little bit, I don't know. I was wondering, here in Nevada, we have no laboratory for research, very little. We have no facility where they're doing research on ways of treating Parkinson's and working with it. Do you have someone that you particularly care about outside the area that would be able to do this? I've been dealing with Davis, and they turned me down. They said, we don't have time, we don't have the room. I've been dealing with Cleveland, and they tried to screw me good. Mm-hmm. I mean, well, it was a misunderstanding we had. Mm-hmm. Okay.
Yeah, we can talk afterwards. I mean, I think that that's tricky, right? There's a lot of factors to consider there. My favorite place in the whole world is UCSF for that kind of thing. But we can talk afterwards. Because you're raising a real complicated issue, actually. Yeah.
Okay.
Yeah.
I can say one thing for research going on. There is a clinical study started at Renown with Dr. Trong, but we are hoping and getting planned for July our mini research symposium like we had last year, and bringing in some people doing some really interesting studies. So that will be a time. Get our newsletter, sign up if you're not already on it. I know you are, and look for something. It's going to be either July or August, depending on how we pull these speakers together. We have one from UCSF doing research on depression and anxiety. We have Dr. Trong doing an overview of what's going on and what is available truly locally, and we're looking to have somebody talking about glymphatic massage, which is another really interesting technique that's been very helpful to some local people already.
Go ahead.
What's the name of the clinical trial that Trong's going to try?
It's one of the UMABs, and I can't possibly say it, so I recommend talking to him.
Is it proceeds?
It's PNE. I can't remember, I'm sorry, I'd have to look it up. I can look it up after.
Okay, so let me just give you 1 or 2 minutes of quick tips, which I hope will be useful and sort of summarize things for you, and then I'll let our next speaker come up. The first is just don't forget about that after-visit summary. It's a thoughtful, useful summary. Don't leave your visit without it. Get on the cancellation list. My office gets cancellations every day. I mean, think of all the situations that come up in your life that prevent you from making a doctor's appointment, unexpected situations. People drop off the list, and you may get that appointment you've been waiting for same day, so get on the cancellation list. Avoid starting new meds on a Friday, just because it's harder to get the care you need. Feel smiles out here, both because they understand what that's like. It's hard enough to get care during the week, right? Here's a good one. Use your pharmacist. Oh my gosh, pharmacists are incredibly knowledgeable and helpful, and often smarter about your medication situation than any doctor walking this earth. So use your pharmacist and be friends with your pharmacist. Bring another set of ears to the visit, not just for the memory and recording of it, but also just to have an outside perspective. And then lastly, if your doctor's in a rush, it doesn't mean you have to be. Is the visit for you, or is the visit for the good doctor? Thanks a lot for your time, and I'm be around for any questions you have.
Thank you.
Yeah. Thanks. Yeah, thank you. You're welcome. Yeah, thanks. Okay. Thanks. Yeah.
Thank you so much, Dr. Kreiss. He's going to be here afterwards. So I would like to welcome Dr. Stephen Phillips. He's a geriatrician who has worked in this area since the 90s. He's semi-retired, he says, but he's busier than anybody I know. So we are thankful to have him. He's going to speak on the 4 M's, and he'll tell you all about it. Please join me in welcoming Dr. Stephen.
All right. Well, thank you. And I want to thank the Parkinson Support Center of Northern Nevada, Mindy and Ann, and our tech enablers, because without my grandchildren here, I wouldn't even be able to get this thing going. So I'm grateful for that. I'm going to start with a very short, it's about a 7-minute video, but it sets the tone, I hope, of what I want to cover today, which is the age-friendly health systems. About 20% of American hospitals offer some form of age-friendly care. Renown is working on it at present, and also the 4 M's. And I'd like to thank Dr. Kreiss for at least covering 2 of the M's in his presentation, and without any prior discussion. So the objective that you're able to understand what an age-friendly health system can be, needs to be, and then reviewing the 4 M's, which really fits well with advocacy. It's not just advocacy as a patient, it's advocacy as a caregiver. And so we'll start with, hopefully, okay. Okay, and here we go. Enjoy.
Look at the data, and the trend is clear. Our population is aging. Care for older adults can be complex, especially for older adults with multiple chronic conditions and social needs. In our current healthcare system, older adults suffer from a disproportionate amount of harm. Older adults may not receive evidence-based care, and they may receive care that is inconsistent with what matters to them and their family. The good news, effective evidence-based geriatric care models exist. However, many of the care models that are best for older adults are often difficult to replicate in settings with fewer resources and do not apply across varied care settings. How can we, as healthcare professionals, provide all older adults with good evidence-based care based on what matters to the older adult and their family? How can we deliver this care reliably every day to every older adult across every care setting? In 2016, the John A. Hartford Foundation and the Institute for Healthcare Improvement, in partnership with the American Hospital Association and the Catholic Health Association of the United States, adopted the bold and important aim that 20% of U.S. health systems would be age-friendly by the end of 2020. Delivering age-friendly care can help to address the challenges faced not only by older adults and their families, but by health systems as well. Age-friendly care is guided by an essential set of evidence-based practices, causes no harm, and is consistent with what matters to the older adult and their family. For health systems, being age-friendly is an opportunity to improve patient care efficiencies and outcomes. The first step in developing this new care model was to analyze geriatric care models, consolidate evidence and lessons learned, and collaborate with healthcare experts. From this rigorous process emerged a set of specific best practice interventions known as the 4 M's framework of an age-friendly health system. The 4 M's address what matters, medication, mentation, and mobility. The 4 M's framework, with the older adult and their family at the center, was then tested with 5 pioneer health systems around the country. Based upon those tests in the pioneer health systems, additional refinements were made to the 4 M's framework. Central to the framework is the idea that an age-friendly health system uses the 4 M's together as a set, adapts the 4 M's locally to the needs of older adults and their caregivers, practices the 4 M's reliably across all care settings, and uses the 4 M's in the care of every older adult in every interaction. Let's take a closer look at each of the 4 M's. In order to meet the care needs of older adults, understanding their health goals and preferences is crucial. This includes assessing, documenting, and acting on what older adults say that matters to them. Focusing on what matters introduces opportunities to know and align care with specific health outcome goals and preferences. Addressing what matters extends across all care settings. What matters includes, but is not limited to, end-of-life care. It is vital to have an ongoing conversation with older adults and their family caregivers about medication. Focusing on medication helps formalize check-ins to review high-risk medication use, deprescribe or choose not to prescribe medications that are high risk for older adults, and ensure medications do not interfere with the other M's, what matters, mentation, and mobility. With mentation, The goal is to monitor the mental and cognitive well-being of older adults, document concerns, and address changes. Focusing on mentation includes efforts to prevent, identify, treat, and manage dementia, depression, and delirium. With mobility, the goal is to ensure that older adults move safely every day to improve function and to do what matters to them. Focusing on mobility reinforces the importance of older adults' ability to move. This can ensure early and safe mobility in the hospital, assess and manage impairments that reduce mobility and lead to falls, create a home environment that is safe for mobility, identify a daily mobility goal that supports what matters, and monitor progress toward the mobility goal. Most health systems already use aspects of the 4Ms in some places and with some older adults. The next step forward is for the 4Ms to be practiced reliably with all older adults every day. So how do health systems scale up to this level of care? It starts with flexibility. The 4Ms framework of age-friendly care is designed for local adaptation so that it can be woven into the fabric of care in any health system. When implemented together as a set, the 4Ms will help to deliver high-quality care that's locally adapted and reliably practiced across care settings. The complex care needs of our older adults are only increasing. Health systems need to improve patient care efficiency and outcomes in order to deliver the best possible age-friendly care. The 4Ms framework is an evidence-based solution for every older adult in every interaction.
All right. All right. I hope that was instructive, and I think it's a nice introduction for the next few slides I'm going to go over. I want to call everyone's attention to this two-sided, colorful. I complimented Anne doing it in color. When I hand this out normally, it's black and white, so I'm super, super impressed. But this is a nice introduction to the 4Ms. The back side is actually where you can write things down. It works very well when you go in to see primary care provider, specialists. I presented recently at our local church a few Sundays ago, and so many came up to me afterwards and said we had sent things out by email, and they had already downloaded. They sent it to children across the country that I want you to understand what this is. We're going to start using it, your father and I or your mother and I. And there's also, that's in the email that was sent out, another 12-page. So we didn't print that, but that is actually a workbook of the 4Ms. All of this is public domain. It was supported through the Hartford Foundation and others, as mentioned earlier. And with that, you can download it and save it, and you can complete this workbook for every visit you go to. So it's a living document as well. Goes along with what Dr. Kreiss mentioned about getting reports. It's a really good tool. And just a little other background about 4Ms. I became involved with 4Ms in 2015. The president of the Hartford Foundation, Terry Fulmer, just recently retired. We were colleagues in different aspects of medicine and legislation nationally. And so I became an early adopter of 4Ms, introduced it to hometown health, prominence over the last 6 or 7 years. But like anything, if it isn't used on a regular basis, it gets forgotten. When I had my private practice, we had 4Ms built into our electronic medical record starting in, I want to say, 2017, 2018. So done that. So it's not a framework, it's a program, and it changes over time. Regardless of diseases, functional status, culture, ethnic, religious background. Now, I realize this emphasizes for the elderly or for those of us aging sooner than others. We just started earlier. But it really works in pediatrics. I mean, it works across all age spectrums because what matters, mobility, medication, mentation are applicable no matter how old you are, whether you're the patient or whether you're the caregiver. And something that Anne shared with me a few weeks ago, and it's a quote from someone who participates in one of the support groups through PSCNN, and it goes along the lines of, every time I go in to see my physician, the question is, what's the matter? I really wish they would just say, what matters to you? So I thought that was really powerful. I wish I'd come up with that. I mean, all the years of being involved with this. But, and it's whether you're healthy or you're frail, across the continuum of care. So right now, there are tools for hospitals to become part of age-friendly health, clinics, nursing facilities, hospice, I mean, any entity across the continuum of care. There are now workbooks and certifications, and it doesn't cost anything because of this funding. And it helps drive decision-making and also incorporates your strengths and weaknesses. So what matters? Know and act on each patient's specific health outcome goals and care. And it could be maybe one goal. It might be two. I don't recommend more than 3 at a time, kind of hard to manage and also hard to complete, if you will. And I'll give you some examples. So one of my side jobs since 2001, volunteer, by the way, is with the National Committee for Quality Assurance. We set all the measurements for healthcare, for Centers for Medicare, Medicaid services, and private health plans. And we, over the last 5 years, have developed what we call the person-centered outcome measures. And it's all around what matters, because when all is said and done, the most important of the 4 M's is what matters. The others are important, don't get me wrong, but the most important in the long run has been shown to be what matters. And so we came up with 12 what matter domains. They're everything from, for some it may be housing. They're house insecure. It may be food. They're food insecure. Could be caregiver needs and concerns. They're one who's concerned about their caregiver, their spouse, who's assisting day after day. Independence. There may be legal what matter concerns, et cetera. So there's 12 of them. And I'm happy to, we'll get that sent out. It wasn't something that we had included in the previous emails. And reason I'm bringing it up is we are in June, we, being National Committee for Quality Assurance, the board, and other members, will be notified if, come 2027, all health plans across the United States, so the Senior Care Pluses of the world, the Kaisers, the Prominence, the Accountable Care Organizations, anyone who is being funded through Medicare, Medicaid dollars, will have to incorporate person-centered outcome measures into their daily practice, whether it's primary care, whether it's specialty, et cetera. And it's happening because Centers for Medicare and Medicaid Services, I have a lot of things I could say about them that I'm not so happy about, but this is one where they've been really, really supportive. And the reason is they've been at the table with us at NCQA and the Hartford Foundation for over a decade, and they see the value. And the way you change behavior, unfortunately in healthcare, is by the purse string. and Medicare, Medicaid has most of the purse string. So I'm super optimistic about that. So, and then the medications. Mentioned earlier, I do think the most underutilized resource is the pharmacist. And I can assure you, pharmacists love to review medications and make recommendations. That's what they're all about. And with Medicare, and even with Medicaid, they can do a thing that's called MTM, Medicaid Therapy Management. It's been a fundable, billable service by pharmacists since 2016. Seldom gets utilized. Also, the way it is most effectively used is using only one pharmacy. So the pharmacy has all your medications. You can have multiple specialists, because we often need multiple specialists, but attempt to only use one pharmacist or one pharmacy. They can then review everything. Also, if you happen to be on a Medicare Advantage plan, and I'm not speaking for one or another, but if you happen to be on a Medicare Advantage plan, they all have doctors of pharmacology that review meds all the time, and they're available. I know for a fact, having been medical director for at least 2 in this community, that they will review medications. It's to their benefit as well as yours. Mentation, the 3 Ds, dementia, depression, delirium, all prevalent, and even more so with neurodegenerative diseases like Parkinson's or Parkinson-like. And then mobility, super important. As a geriatrician, function is more important than what I do with someone's blood pressure or with their blood sugar. It's function. When we become less functional, we become less independent. And this goes back, history repeats itself. In 2000, the World Health Organization came out with this statement that the health of a society is independently related to its functionality. More functional a society, the healthier the society. And it didn't talk at all, it was after it reviewed hypertension, blood pressure control, cardiovascular disease, neurological diseases, et cetera. So with what matters, by advocating for yourself, it allows your caregivers to know and therefore act on what is important to you. And the point about being rushed, yes, it happens, but I do find more colleagues, when they get information ahead of time, they do actually look at it. And for many reasons. And I won't go into all the reasons that they do it, but a more complex visit is a more profitable visit. So I think you get my point. And by identifying what matters, it allows for better documentation and a better plan that can be developed. And then why Medicare and health systems like using what matters is, it has been shown in over 100 peer-reviewed evidence-based studies that the use of all the 4 M's, but especially what matters, reduces hospital stays because you have a plan in order to get home or get to the next care level. You have already in place folks that can help, family, hired caregivers to get home. Drastically reduces the use of intensive care unit, which is by far the worst place to be. If you have to be there, you have to be there. But it's not. The outcome is not always good, and it does increase the use of hospice. And hospice is a benefit. Dr. Kreiss shared at lunch his working with a hospice in the Bay Area. I've been involved, I have founded 5 hospices in my career. Never as an owner. I always liked being independent, but I had no problem being the medical director for the hospice agencies, because I strongly believe it's a 180-day benefit at minimum when criteria are met, and it's so underutilized. And by accepting hospice does not mean one gives up. Hospice does not mean no care. If an agency implies that, I'd find another hospice agency. That's not how it was intended. And so it's also interesting, you know, Medicare was approved, signed by President Richard Nixon. Hospice was approved and signed by Ronald Reagan. So just a little, at your next, whatever they call that, trivia game, you'll know those two. Medications, and again, the role of the pharmacist. De-prescribing. That's actually a measure through National Committee for Quality Assurance we built into all health plans 3 years ago for certain medications, the ones that increase risk of falls, the benzodiazepines, like the Ativan, the Valium, the antipsychotic medications, inappropriate usage. De-prescribing is a market of itself now, and for good reasons. When someone is put on, let's take thyroid medication at the age of 40. In the age of 70, they're on the same dose. Well, their ability to clear that medication, you know, through the liver, through the kidney, has probably reduced by 30 to 40%. That's way too much medication. And so stepping back, you know, in geriatrics, the saying, start low, go slow. And there's a lot to be said about that. You don't need to hit a home run. I've actually always felt if I can just hit doubles, I'd be better than most ball players. So, you know, you're making progress. So that review of medication, that's why the pharmacist is critical in that aspect. It may be discontinuation, but certainly dose reduction. And then adverse drug reactions, so interaction between 1, 2, 3 different medications. If you go from 5 medications to 8 medications, you have about an 8-fold or 8-time increase in potential for adverse reaction. It's exponential. It increases morbidity, so illness, disease worsening, hospital admission, healthcare costs. So that's why it's an important M in the 4 M's. The mentation is something that had Jared, who will be speaking with Mindy later, we talked also at lunch just about, you know, the lack of, at least I mentioned, the lack of screening by primary care practitioners, so MD, DO, nurse practitioner, physician assistant, of cognition. You know, we end up, you know, testing someone when they should have been identified 12, 18, 24 months before. Because there's this thing called minimal cognitive impairment, MCI, which is a precursor over time to dementia, whether it's Alzheimer's-like or it's vascular-related. And there's a great tool for earlier identification. And the reason to identify sooner than later is that you can intervene. And that was something I shared with Jared, I'm not real big on the medications. I never have been. And I've had some colleagues who would actually throw them away when someone came into the office with their medication for it. I get a thumbs up from Dr. Kreiss. Yet, if I identify someone with mild cognitive impairment on a test that takes about 10 minutes and tests 7 different functions within the brain, and they're diabetic, and they have a hemoglobin A1C of 9 or greater, I can use that information to get them to work more. That's when it becomes, what matters is I want my hemoglobin A1C 7.5, maybe 7. Why? Inflammation. Inflammation, you will just progress on with from your mild cognitive impairment on towards dementia. The other is someone who still smokes. Boy, get someone to stop smoking because they see that they have cognitive impairment, that becomes real, right? I think there's very few people who want to have a diagnosis of mild cognitive impairment. knowing that I could prevent getting dementia if I just do some life-altering activities. And then mobility. And this is, it's statistics, but they're important statistics. 1 in 4 of us, and I consider my wife and I as elders, we qualify, and 1 in 4 fall every year, less than half tell their physician. That's why you probably get sick and tired of hearing probably 3 times in a primary care visit, and probably the form you filled out before you even went into the exam room. Have you fallen lately, right? Well, it's a big thing, that you lose mobility, you lose function. If you lose function, you lose independence. And then 1 out of 5 falls causes a serious injury, broken bones, traumatic brain injury, #1 cause for traumatic brain injuries above the age of 65. And then 3 million visits to the ER related to falls occur. And then the risk factors. So having a home safety evaluation is very important. Review of medications. Exercise program, whether it's Tai Chi, some resistance exercises, and regular vision checks, correction when indicated, identifying home hazards like the throw rugs, like the cords, and then walking and balance difficulties. So this is coming to the end on it. So the age-friendly health system, it is the 4 M's: what matters, medication, mentation, mobility. So we need to assess and then be able to act on it. You are the ones with the power to, provide that information. And yes, electronic medical records would be nice if, you could just extract all that as a provider, but I think being your own advocate is the most important thing to do. And one final thing I forgot was in January of this year, all hospitals receiving Medicare, Medicaid, and for someone like Renown Health System, they have to address the 4 M's at time of any admission or emergency room visit by law. If they don't, a system like Renown stands to lose $10 to $12 million in revenue, $1 million a month. So, and I know for a fact they're doing it, Carson Tahoe is, the UHS hospitals are doing it, St. Mary's is doing it. Now, the important thing is, what do you do once you have that information? So if you have the need to be in an emergency room or a hospital, that information should be asked of you and part of your discharge summary. So again, how are you, addressing the 4 M's? How can you use that when you're meeting with healthcare professionals? So I thank you. I'll some other resources that we can provide, and then any questions, happy to answer.
Before we get to the questions, I just want to apologize to the Zoomers. Apparently the video did not show to them. So we will be sending out a slide deck after this so that everybody will be able to see it, and you can see it multiple times and absorb even more in that way. But we apologize for that. We will take questions now. Yes?
Yes. I want to talk about what matters. There are groups like this particular group here, models. There's research groups all over the country. Places like Renown and research hospitals like that who depend on sharing information between each other. But with the federal funding the way it is, the federal government has hit Medicare very hard. It's been hit a lot of the people that can no longer afford to share all that information because it costs them money to acquire it. So they keep it personal between themselves. And I would like to make sure that there would be some way to fund those people, that whole organization, that whole group of people, to get them to share that information. I'm talking about mainly the research groups all over the country. I'm finding out in different research groups all over the country, they all have research in certain areas and they're not sharing it with anybody else. And that's important information all over the country. And the reason they're not sharing it with anybody is because it's money. It costs them money to acquire that information. And they're not getting paid for it. They're relying on private funds and themselves to be able to provide the money to get that information, and they're keeping it to themselves. That's not right. Something not right.
So I'm hearing the question is more, how can we get all the different institutions, not just our own providers within our community to talk to each other, but all the institutions working on different issues to talk to, and that's...
Including this group.
Of course.
We're dependent on money here in this group, and we're not getting any federal funding. We're dependent upon the people to do donations.
We are.
Yeah.
We are. That's a great point that I think Jared will be talking a little bit about some national issues and where we can all get involved in talking about making sure people talk.
Yeah, I appreciate what you're saying, but I think it's really important to separate proprietary versus non-proprietary. And what I mean by that is all the things I've been talking about and what hospitals are doing now is being shared everywhere. But it's that private research or any private foundations, you're right, if you think you have a bigger bat or a shinier ball, you don't want to share it. And you're absolutely correct. And but it's that distinction of proprietary versus non-proprietary.
Well, that says what is the most important thing that comes to mind, and that's exactly what I was...
Yeah, and I think that's, yes.
That is important. We have a question on Zoom. Hard to find a home safety evaluator, an occupational therapist or such. What is the best way to go about finding a home safety evaluator?
Right. So with the closing of the continuum, it's become more difficult, certainly. Now, one is if one can qualify, and most times one can qualify for a home health assessment, through Medicare. Your primary care provider orders it. That would incorporate a home assessment. Short of that, I'm not aware of currently any, if you will, freestanding occupational therapists. Certain systems, so within Senior Care Plus, they have offered home evaluations by one of their occupational therapists. I don't know if maybe Mindy or Ann know of any other organizations locally, but that is a tough one. But there's actually I do have a nice 2-page or 4-page handout that you can do your own. And it really is a very user-friendly self-assessment of your home. And I'll make sure PSCNN has it, if I can find it.
But often your insurance will pay for a home evaluation by occupational therapists, and the primary care physician can prescribe that. Right. And that's a way to make sure that, for example, the grab bars are at the right height. Mm-hmm. Obviously, my height would be different than most people's. And things like that. So looking for safety features, how do you bring your laundry basket to your washing machine? Do you have a laundry basket that's on wheels that you can pull behind? Is there a way to put it on your walker? Things like that. So there's lots of tricks that occupational therapists would have, and if you ask your good primary care provider, they can often do an appropriate referral.
Yeah. Yes, sir.
Both you and Dr. Kreiss mentioned the importance of a pharmacist, but many of us have gone to mail order pharmacy. How do you engage the doctor of pharmacology that your healthcare provider offers?
Right. The question is, when you use mail order, how does one then access a pharmacist? So if your mail order is through a Medicare Advantage plan, which often it is, you just talk to your Medicare Advantage plan, locally, Prominence, Senior Care Plus, and Alignment, and say, I want a medication review, because they have in-house pharmacists.
So just ask for it.
Just ask for it. And probably in the end, you'll be educating your primary care provider that this service is available. Because they don't, I mean, literally, when I was the founder of Senior Care Plus in 1996, Hometown Health, and left and came back right around COVID. There was some shakeups that occurred, or changes that occurred. And so I came back until just last year. And we went from 2 full-time pharmacists to 5 because we increased our outreach for medication therapy management with a return on investment of 3.5 to 1. So not a bad return. Okay, well, thank you very much. I really appreciate. And
Any other questions
thanks.
on Zoom? Just don't want to miss that, just in case, since you guys aren't here. Not seeing any others. Okay. Thank you so much.
Thank you so much. All right, I am pleased to introduce Giorusso-Khlok.
Nailed it. Yes, nailed it.
Perfect. Jared works on national advocacy for the Parkinson's.
Michael J. Fox Foundation for Parkinson's research.
That's right. So I don't know if you heard him, but it's the Michael J. Fox Foundation for Parkinson's Research. We're so excited to have him today as well. He's going to be speaking on
Advocating for Parkinson's policies. The handoff has happened. Hello, everybody. Good afternoon. With the dual last name, my last name was already hard, so I figured in marriage, make it even harder for everybody to mispronounce and misspell. So, and as a third speaker, I know my job is to be energizing, engaging, and as brief as possible so that everybody can get to their activities. But very, very thankful to be here today. Thank you to Parkinson's Support Center of Northern Nevada, and thank you to Ann and Mindy who invited me here to talk to you all today. Your advocacy here, particularly through Mindy's advocacy, is so incredible that she could probably be doing this presentation, but I'll do the best I can. So again, I'm with the Michael J. Fox Foundation for Parkinson's Research, and I love that I'm here to talk about advocacy along with other speakers who talked about advocacy. It's been a core part of my career for nearly 20 years. I am based in the Sacramento region. My territory for the Michael J. Fox Foundation is the Western States. So I'll talk a little bit about what that looks like. What happened here? Oh, computer went to sleep. I was that boring. Okay, wake up. We have our state relations divided into territories. I'll talk a little bit about that. And I've been doing advocacy in higher education for the Alzheimer's Association for college students during my career. So I'm so grateful to be able to do this in this space with the Parkinson's community as well. And advocacy is important. It's important in all of these different settings, but with respect to Parkinson's, it's important because it's not just an issue that's impacting everybody here, but it's an issue that impacts everybody. It's a public health issue. And it's an issue that we need, because of that, we need policymakers to really prioritize and to be thinking about in their policy making. My presentation is going to talk a little bit about what we're doing, some of our priorities, but really the power of your voice in our advocacy, your experience, the power of storytelling. I know it was already mentioned that collaboration is magic with your care teams, but collaboration is absolutely crucial for us to be able to get any of the things that we're asking for from our state leaders and from our federal leaders too. And so it's so great to be able to talk to you about that and to be able to do this work. I got 2 screens here, so I gotta. Okay, so Michael J. Fox Foundation for Parkinson's Research is started by Michael J. Fox, and everybody here knows who Michael J. Fox is, I think, right? Everybody's seen Back to the Future, probably. This is Shrinking Now, where he does a great job of, showing kind of the Parkinson's experience. This is definitely where I start to see my aging, though, in terms of Michael J. Fox, because when I talk to people, younger people, now younger than me, they have no idea who Michael Michael J. Fox is, so the fact that I know it puts me in a different age bracket, which, is life. But Michael J. Fox started the foundation in 2000. He was diagnosed with Parkinson's at the age of 30, and it's so incredible that somebody who, at the time was such a big star, I think still is a very big star, that he could be diagnosed so early, and we still, the idea of the Parkinson's person is still exactly kind of what it is today, 25 years later after him being diagnosed. The foundation is the largest private funder of Parkinson's research in the world, and you can see some of the data points here as well. We focus on research, both by funding research, but also through what we're asking our state and federal leaders to invest in. Advocacy is key to not just our research, but to our federal and our state policy priorities. We had, so about a week ago, we had in California our first ever Parkinson's advocacy event where we had 55 people come to the state capitol from across the state and talk to state policymakers in the governor's office about key priorities that we have, both funding research, trying to get the state to ban pesticides that we know are linked to the development of Parkinson's, more home and community-based services for individuals in the community. And one of our advocates talked about how, we had folks who have done government affairs in their careers. We have people who have, done lobby visits and that for different organizations. And we had people there who had never done this before and who were super nervous and were, had no idea what this experience was going to be. And one of our advocates said that everyone's an advocate. Not just that they were there for the event, but we've all been advocates since we were children, right? We advocated for, wanting an additional, thing at mealtime, right? Our son wants cookies all the time. He's an advocate for cookies, right? As we grow up, we advocate for ourselves in so many different ways. And when it comes to policy advocacy, it's about demystifying the experience and the process so that everybody can do exactly what they know how to do, which is tell their stories, ask for what they need, and ideally doing it collectively can get those things. For the Parkinson's community and for the Michael J. Fox Foundation, our federal and our state policy is fairly new. We've been doing it for about 10 years now. But this work has happened in different states. It was happening in Nevada and in California. When I was with the Alzheimer's Association, I saw the Parkinson's community advocate for a registry there and learned more about their work as well. But over the last year or so, we've drastically expanded our staff in this space. For the state affairs team, we went from 2 people covering the entire nation to now 4 people. So we have every state covered with 4 people. And then our federal team has increased as well. And this means that we're really trying to do much, much more than we were doing before to activate in states and activate in our national capital. Our main focus, as I mentioned, is federal investment in research, and we think that this issue at the federal level and at the state level is it has to be a bipartisan issue, right? Because in state legislatures, I'm dealing with, in California where it's all Democrats. I was also advocating in Utah where it was all Republicans. Here in Nevada, you have a bipartisan state government where you have a Republican as governor and you have a Democratic state legislature. And at the national level, right, everything switches from party to party, and we can't depend on one political party to hinge all of our hopes to that they're going to be focused on something and ignore the other group. And we have to make the case that Parkinson's doesn't care what political affiliation you have, right? Like Parkinson's impacts everybody, and so our advocacy has to impact everybody as well. And the work of our advocacy includes people living with Parkinson's, care partners, our researchers. In Washington, we have a great researcher out there who's going to help us with some of our bills that we're moving in the state of Washington as well. It's an opportunity for anybody who's interested in this to get involved in a number of different ways. The why do we do this? There are a number of reasons. One of them is because of you all and because of your experiences. We know kind of what the needs are in the community, and we know that there are needs and there are problems that need to be solved. we have to do this because it's a growing health issue. Parkinson's is the fastest growing neurodegenerative disease in the world. You know, when I started with the Michael J. Fox Foundation in October, a number of people have asked me the same question, which is, do I have a relationship with Parkinson's? Do I know anybody living with Parkinson's? It's something that we ask people who are talking to state legislators. Do you have a relationship with Parkinson's? The assumption there is if they do, they might be more amenable to do what we're asking because they have a better understanding. I don't. I joined this work because I knew the reputation of the organization. I knew that the work was important. But because it is the fastest growing neurodegenerative disease, I know that at some point in my life, I will have a family member, a friend who gets Parkinson's, or because of the growth level, and because when I worked at the Alzheimer's Association, it was the same experience. When I started, I had no family relationships with Alzheimer's, and then my grandmother developed Alzheimer's and passed away. My aunt developed Alzheimer's and passed away. It's something that as you live long enough, you learn about more people, and you meet more people, and as the fastest growing neurodegenerative disease, you know that if you don't have that relationship, you're going to. For us, we know that right now, clinical treatments, people are still using clinical treatments that have been, that were created 50 years ago, so we know that there has to be more momentum on that. There is no cure. And our organization, the Michael J. Fox Foundation, we have a tagline, we're here until Parkinson's isn't. So our goal is through our research, both the research that we fund, but the research we're trying to get the federal government and states to fund, ultimately we get to a place where there's a cure and where we're eliminating the things that we believe are causing people to get Parkinson's. Next slide. Our federal priorities. So I think, Mindy, you were in DC a month ago.
Actually, Vicki. Here now was.
Vicki, thank you. So Vicki probably knows better about our federal policy priorities than I do. I think that there were great talking points. Unfortunately, I missed it because I got hand, foot, mouth from my son, and my face looked disgusting. But we have a number of things that we're looking to get from our federal legislators. We are looking to get the NIH to fund more research. We are looking to implement the National Parkinson's Project. We are, I think this year around, the Healthy Brains Act was something that we're advocating for, which is helping us understand more of the environmental factors that cause Parkinson's. And then there's also the work that we're doing with respect to a pesticide called paraquat. During our federal advocacy and in our state advocacy, we're asking all of our decision makers to try to ban the usage of this pesticide. In the state of Nevada, paraquat is used. It's used as 0.5% of all pesticides used in agriculture here. And it's kind of the same case in most other states, but we still have a lot of work to do to try to do that. And if we got the EPA to ban it tomorrow, we wouldn't have to worry about any of this work at the state. And so that was something that we asked for. As I mentioned, the National Parkinson's Project, this was signed into law in 2024, and it's modeled after the Alzheimer's National Plan, which was created about 20 years ago, a little bit more than 20 years ago. And this is, in some ways, the roadmap that our group and other groups are looking at for our opportunities to see much more investment from the federal government. Right now, the federal government invests just over $300 million in Parkinson's-specific research every year. Our ask for research funding is about $600 million a year by the year 2028. Alzheimer's annual research funding is $3.9 billion. So there are a lot of reasons why you see that discrepancy. One of them is because 20 years ago, they passed a national plan and used it as an anchor to be able to start to drastically increase the amount of research that is being funded. And it's something that with Alzheimer's, as with Parkinson's, we see bipartisan support. For the Healthy Brains Act, we saw a Democrat and a Republican introduce that act. When it comes to everything that we're doing in this space, we see support from national Republicans and national Democrats as well. And we see this as the way to get to where we need to get to. So for the National Parkinson's Project, we absolutely need to see this implemented. After passage, we are still seeing We're seeing it be kind of slow to be implemented, but just recently we saw people be appointed to the council, 3 of which are affiliated with the Michael J. Fox Foundation, one of which is our CEO. So we think that there is movement there, but there is still the opportunity to urge our legislators, urge the White House to continue to invest in this, to invest in our research, but to invest in this plan, because this plan will inform not just research, but it will inform care, it will inform how the federal government thinks about Parkinson's in a number of different ways, and it will grow from here as long as people do exactly what we need them to do, and that takes our voices and our advocacy to be able to do that. Our state policy priorities are very similar to our federal priorities, because our state legislators and our state governments can do some of the same things that the federal government does, but at a different level. And I'll use this as an opportunity to talk a little, just very briefly, about the differences between our federal advocacy and our state advocacy. Obviously, we're talking to Congress members and senators, so 2 senators for the state of Nevada, when it comes to the things that we're asking for at the federal level. With respect to the state, we have a state house here in the state of Nevada, and we talk to the governor. So, technically those are the differences, but the way I look at some of these differences is when we're asking for things at the national level, things move very, very slowly there. To be able to get anything takes years and years and years of the same storytelling, the same messaging, the same advocacy to start to see that movement, because Congress moves slow. It moves slow for probably all the reasons that we're thinking about, and some of the reasons we're not thinking about. At the state level, I love state advocacy. The vast majority of my experience has been at the state level, and what I love about that is you can take an idea that you have in the fall, and if you have a legislative session, that idea can be a law by the end of the next year. So things can move very quickly there, and that creates immediacy. If we have something that we think we need to get done, we can ideally in the state of Nevada get it done with a legislative session, which you have one this upcoming year in 2027. We can get something done in a year, which is incredible. The other thing that helps with state that that we think is a leverage point for state is if we can get states to do something, that can be a model for what the federal government should do. So there are a number of benefits for us working in both spaces to be able to get the things that we're looking for. Yeah, obviously we're looking for research dollars for states to contribute to research dollars. That's a little bit trickier because the federal government can fund as much as they want. They can run a deficit. States can't run a deficit, and so that creates a limitation for the amount of dollars that they can spend. However, last year we had a huge success in the state of Texas, which funded $10 billion in neurodegenerative research, which is huge. They have a huge surplus, but you could imagine a Republican-led state legislature, a Republican governor, everybody there said that this was a good idea. And a bill passed the legislature, signed by the governor, went to the voters in Texas, and passed with over 65% of the vote, because people understood that this is important. This is an important space for us to be investing in $10 billion. In California right now, we're looking for a ballot measure that is running through the legislature right now that would fund $23 billion in research. These are some large numbers. In Utah, we were able to get $20 million in research across areas. So it will look different in different states, but that doesn't mean that states don't have a role in investing in research. We're also thinking about access to care issues. For California, I mentioned some of the things that we've done in my short time here is advocate for, right now, you could imagine with state Medicaid programs, there are a number of cuts. In California, we have what's called in-home supportive services, and there were potential cuts to in-home supportive services, which are crucial for Parkinson's community and a number of communities. We were advocating against those cuts because we know how crucial that service and support is. We are also advocating for an increase to home and community-based services, which is another state Medicaid-funded program, which helps people age where they'd like, whether it be at home or in care settings. This is something that is a growth opportunity for us, and in the state of Nevada, it will look different than it does anywhere else. It will look unique to the state of Nevada, but it's something that for the year 2027, if we have ideas of what we could potentially be doing here, I think we're very much open to those ideas and to figure out not just, how do we invest in research and how do we prevent exposure, which are, for in an ideal world, those are for people who are not currently living with Parkinson's today. But we also want to think about policies that would impact everybody, right? And that's care policies. So that's where we have a little bit more imagination and more opportunity to be informed by everybody's experiences and figure out what could be possible here in Nevada. And I've talked a little bit about environmental transparency. I have another slide where I can talk a little bit more about that. As I mentioned, you all have been doing a great job already in the state of Nevada. You passed SB 390 in 2023. I'm sure how many of you are familiar with this bill and what it does? I see a couple of hands. I'm learning about it over the course of this past couple of weeks, getting prepared for this presentation. It established a Parkinson's research registry, unfortunately an opt-in research registry, and is one of, I think there are 13 states that have a similar registry that's stood up right now. Some are more funded, some are less funded than others. There's still opportunities to advocate on this issue because there's still the question of implementation and of funding, and Mindy, you might have more information about that. But this is something where we don't want to just take the win and forget about it. We need to take the win and we need to see implementation in a way that was envisioned in 2023. You want to add anything?
Sure. I can say that in 2023, I kind of spearheaded this movement, and we were able to get a champion state senator and some assembly people super excited about it. In talking to legislators, we came with the idea of a Parkinson's research registry mandatory reporting, which is sort of the gold standard where physicians would say, I have diagnosed you, I am now entering that information into a state registry, a state document, so that we can keep track. There were a couple of problems with that. There was a pushback from the State Hospital Association, as well as quite a few physicians who did not want another mandatory reporting thing. They also said, gee, it's really hard to diagnose Parkinson's disease. It's not like adenocarcinoma of the breast where you get that biopsy and you know exactly what it is. As you all know, it takes sometimes a long time to get a proper diagnosis, and sometimes it's the wrong diagnosis and things change. So they said it wouldn't be a valid registry. They also said, why are you limiting it to Parkinson's? So our statewide research registry is an opt-in, meaning it is for patients to choose to participate, and it is for all neurodegenerative diseases. So it's Parkinson's, Alzheimer's, MS, ALS, Lewy body dementia, you name it, to be housed at UNLV. It did come with some funding. It kind of got started and stalled. So we are in the process of rebooting it, if you want to say. So that's where that is.
That's where that is.
Mindy, so could you just explain why it's so important to opt in? I mean, what it means for having a registry?
Right, so the dream for this registry, the way it was set up, it was going to have two parts to it. One is going to be a website for the general public to go to learn about brain health, to learn about all the different studies that they could participate in, and then choose to enter their data or choose to enter a research study. And then the other component to this registry was to back-end fill it with de-identified data from Medicare, Medicaid, pharmacy records, things like that, because who gets prescribed Sinemet but somebody with Parkinson's? So that would be a way to pull in that data. It is a complicated process. We've worked with the state of California because they have a registry. Actually, it does do all neurodegenerative diseases also, but they have over 400 people that they've identified that are in their registry that actually live in Nevada, so they would be able to automatically drop that information in. We don't have that structure yet to do that. But why is this important? Anybody understand why a registry is important?
It is important because otherwise we don't know how many people have the disease in what area, right? If we want to know that paraquat's used in Smith Valley and Yerington area, and there's 10 times the number of cases of Parkinson's there, we don't know that because we don't know who has it where. Does that make sense?
Thank you.
Yeah, quick question. When you say it's an opt-in registry, I mean, I've never had a doctor say, do you want your information put into the registry or not? Who asks that question?
Right, that's complicated. That's why the dream, of course, is that it's mandatory reporting, because then there isn't that complicated intermediary step. But the way it was designed is that there would be a pamphlet that every doctor's office would have and say, gee, you want to know more about brain health? Here, go to this website. It's not created yet.
Yeah.
If I can just, so there is one thing that all of you, myself included, are asked to opt in, and that's the health information exchange, the HIE. Your primary care physician, sorry about that. So your primary care physician or even specialist, every year you have to sign your HIPAA form, privacy form, and it also has a box to check in Nevada. Do you want to be on the health information exchange or not? So that's an opt-in. For the same reason this registry is opt-in versus mandatory. It was resisted to be mandatory. And the health information exchange is the one that when you go to Renown and records are generated, or St. Mary's or wherever, it goes into a state repository so that myself as a geriatrician have a new patient, they're on the health information exchange. I can pull all the records that have been generated. And in this state, every major hospital health system is part of the exchange. So there is one, that's the only one that I'm aware of that's truly an opt-in. And that's been around 15 years, the HIE. Maybe you don't even know it exists, but it does.
Yeah, these registries in the states that we have them, I mean, we look at them as a valuable tool, right? We were talking a little bit about paraquat, which I'll talk about on the next slide, but to understand, like, if a community has a higher prevalence of Parkinson's, right, we can better understand what potentially is causing that, but also that the community needs to step up and provide more services, right? Like, without that understanding, we are just kind of, I wouldn't say shooting in the dark, I just said it, I guess, but we're doing these things that we know are good-spirited. In the Central Valley in California, we think of it as a Parkinson's belt because we believe that exposure to pesticides contributes to Parkinson's. But that is through people's storytelling. That's through people kind of creating that perspective. That is not as data-informed as it needs to be. And our legislators, they need our voices, and they need us to be able to say, and here's the data to prove it, right? These registries potentially give us that, and that gives us a foothold into all the other things that we need. So I've talked a little bit about paraquat. I'll talk more about it right now. It is an herbicide that is banned in 70 countries. It's banned in every country that produces it, but not in the United States. It is used in most states, a very fraction of the amount of pesticides that are used. And since I think the 1970s, when it was invented, everybody really kind of understood at that point how dangerous it is. If you were to consume a spoonful of paraquat, you would die. There is no cure to it. In the city of, or town of Doris, California, Northern California, there was a paraquat spill. I think it was like 80 gallons, and they had to issue a shelter-in-place order for the entire town. If you were driving your car, you were told to wash your car before bringing it home. You were told to turn off your air conditioning or any kind of circulation in your house. That's how dangerous it is. For us, it's important for us to be thinking about it because of all the data that shows shows exposure to paraquat produces higher levels of Parkinson's. I think there was an NIH-funded study that showed 2.5 times higher chance of having Parkinson's if you were exposed to paraquat. And so we are in multiple states trying to get states to ban it. We're also trying to get the federal government, who could do this tomorrow. They could do this today, actually. They could do it any day if they wanted, to ban it. I don't know how likely we're going to be at the federal government, but at the state level, we have. Did this turn off?
You did. Maybe the battery died.
I bored this too to death. Hello. So we have a number of states where the Michael J. Fox Foundation, a number of other organizations are looking to ban paraquat. In our western region, our opportunities were in California 2 years ago, where the ag industry was able to prevent us from creating a ban. In the state of Washington, we introduced a bill. It never was heard. In the state of Utah, we wanted a 1,000-foot buffer around schools that the Farm Bureau prevented from even getting a hearing. So this is a big challenge for us, but we think that it's an important challenge because no one who lives in an area that is providing the food for our nation in California and Nevada, anywhere, should be exposed to something that potentially can have them have a much higher chance of having Parkinson's. If we're successful this year in any of the states, it could potentially be in the state of Vermont. I think we have our government affairs person says 95% chance, so he's leaving himself a little wiggle room just in case things go wonky there at the end. But we do have a chance of doing this in different states, and it requires people telling their stories and talking about how important this is, because there are going to be a number of people, just like with the registries, just like anything that we do, who are going to talk about why we shouldn't do these things, right? This is going to be too hard. I am already super overwhelmed. It's going to cost too much. If we're not telling our stories, if we're not explaining what this means for people, then the other side is always going to win. Yes?
Have you ever heard an explanation from the farmers as to why they can't stop using it?
So yes, and every time we do this, they give us a number of, I think, some legitimate concerns and some less legitimate concerns. So it's a highly effective herbicide. It's as effective as anything. So there are a number of different replacement pesticides that can be used, and the combination of those, all of them work. And in those 70 countries that have banned paraquat, in some cases on different crops, they have outproduced us. But the ag industry's argument is the effectiveness and the cost effectiveness of paraquat make it an essential tool in the toolkit. There are other concerns that they have. There's the slippery slope concern, always a slippery slope concern. I think in the state of Minnesota, where we have a paraquat ban, there was the sugar beet farmers who do not use paraquat who opposed our bill, because if it's paraquat today, it's going to be something tomorrow, right? So it's a slippery slope argument, which I think maybe less legitimate. Like we care about the things that we know cause Parkinson's, right? Like that's our line. So we would say this is where we want to do this work. We don't, on other pesticides, we're not trying to make it harder for the ag industry, right? I heard in California in particular, there was some concern around the science that we're using to base this off of. We feel, Michael J. Fox Foundation for Parkinson's Research, we feel like our credibility in research is fundamental. So we wouldn't be out here because it was wonky science. But you could see in a number of other instances, tobacco is a good example of when people were trying to talk about the health risks of tobacco. There were a number of research studies that showed that tobacco did nothing and it was not harmful, right? So some of these strategies are tried and true strategies to prevent against things like this. Some, like in the state of Vermont, we had an exemption in the bill that in an event of an emergency where paraquat was the only thing that could have salvaged crops, that the governor could call that emergency and still use it, we accepted that amendment. So we're trying to be mindful, but we're also trying to be very clear. We think the science is clear, and if you're living in a rural community, we don't think you should be exposed to something that can contribute to you getting Parkinson's. Hopefully, does that kind of...
Yeah, I guess I'm just thinking, have we seen the numbers? Like, they probably don't share the numbers, like paraquat costs this much. what was done this year, this is what this would cost.
Yeah.
Saying,
What?
cost my money.
That gets to a question that I hear in a number of places, which is what are the alternatives and what do those alternatives cost? The challenge, I think, for us, we work with a number of national organizations on this work. One is the Environmental Working Group. We don't want to, in our work on paraquat, advocate for the usage of other pesticides, right? And that's kind of, I guess that's our slippery slope. But we do want to say that we know that ag industries can succeed without paraquat. We've seen it done in 70 different countries. We know that that can be done here in the United States as well, and we think it needs to be done here in Nevada, right? Like that would be our argument here. Okay, how am I doing on time?
We'll wrap up in 5 minutes.
5 minutes. So this is last functional slide. I have a couple of other ones that have some resources. So what does advocacy look like in practice? In this case, advocacy looks like telling your story to people who can influence these different issues that I talked about, right? And telling that story, it can look different in different spaces. It can be calling your local legislators when we have something to ask them for and asking them to support a bill, right? If we have a bill next year that bans paraquat, it means calling your local elected officials and saying, we need you to support that bill. It could be sending an email. It could be if you're somebody who loves social media, right? I love social media. It's posting on social media about these efforts and spreading awareness so that more people know that this is an opportunity to make real change. There are some less time commitment activities that look like that are advocacy, and there are some more time commitment activities, right? Calls, emails, these types of things. When I worked in the state legislative office, we were still getting faxes, right? I don't know if anybody's getting faxes anymore, but potentially you could fax your legislator, right? But you could also go to a district office or meet with your legislator in person. State legislators do town halls and open events, right, that we can attend, and we can go there and talk about our issues. Advocacy can happen in a number of different spaces, and when we have things that we're asking for here in Nevada, what we're going to be asking folks to do is, are you interested in doing anything, right? Are you interested in making a call? Maybe you're interested in attending a meeting. Maybe you're interested in going to the state capitol and testifying on behalf of an issue, right? Like, this is what advocacy looks like, and the investment is only the investment that you're looking to make in this, right? Like it can be what you need it to be, and the more people who are willing to just take one additional step towards making these improvements by telling your story, the more that we can see every one of these changes that we're talking about actually happen. One quick last thing is that telling your story piece is so important. During our State Advocacy Day in California, we had advocate leads who talked about the importance of, when you're going to meet with a state legislator, writing your story down. And, like, depending on your comfort level, you can talk a little bit about that and share your story, like share your printed version, right? Being able to kind of put into words why your experience relates to what we're asking for is the key to this, and doing that in a number of different ways works. I've seen it work. I've seen it work in a number of different places, and I think in California we're going to see it work with what we're asking for in the research space as well. So when we have those opportunities here in Nevada, the goal is everybody here who's interested is interested in joining us and being able to tell your stories in whatever way you're interested in doing. And we have a few other ways to get involved. I think this PowerPoint will be shared with folks afterwards. So we have our michaeljfox.org advocacy link, so that's where you can sign up to hear more from us. We have fundraising opportunities with Team Fox. We have our Parkinson's Buddy Network as well. And then we have the opportunity to participate in clinical trials. So there are a number of ways to get involved. I'm very interested in you getting involved in advocacy. So I think that's it.
Questions? Any questions? Any questions on Zoom?
Oh.
Yes.
On the paraquat, does it leave a residual in the product that it's spraying on top of?
So my understanding is it's never sprayed on anything, like if it was used on strawberries and it's not sprayed directly on strawberries, it's sprayed on weeds that potentially could impact the crop. And
Weeds are with the strawberry.
yeah, well, I think it's on the ground, like for tree crops, it's weeds that would be around the trees, right? And our understanding is that there's a drift, so once it's sprayed, it could potentially drift up to 2 miles. So paraquat is a highly restricted pesticide. If you're using it, you have to, in most cases, have a license to use it, and you have to use protective equipment. That was another argument we heard from people when we've been trying to ban it, is that there's already safety measures put in place, but because of that drift issue, that's where we think that communities that are around where this is happening are impacted as well, and they're not putting on protective equipment or anything like that. So that's kind of where we think the exposure happens.
Yes.
Did I understand correctly, you have no idea what the population of Parkinson's is?
Michael J. Fox Foundation, we believe that the population is roughly 1.2 million individuals nationally living with Parkinson's. I think
But you don't know because of the lack of the registry.
We don't know specifically because of the lack of the registry, exactly. I'll just give a quick example. With Alzheimer's, we have a number of about 7 million people living nationally with Alzheimer's. Those numbers are from census data, and then the assumption of demographics across the nation based on prevalence, right?
Parkinson's a census question?
Parkinson's isn't, but what we would do, I think in the numbers that we have, it's the amount of people based on the age of individuals is kind of where we get those estimates, but those are estimates, right? We could do better than that. And knowing specifically what communities are higher prevalence gives us even more information. So that's where the gaps are, the difference between our estimates and real data.
Thank you.
Part of raising awareness is getting our government officials to recognize April as Parkinson's Disease Awareness Month. This year we had a fabulous intern, Jasmine, who's been doing our cameras today, and she was instrumental in asking all our legislators to give us some proclamations. And today we are honored to have our County Commissioner Alexis Hill here to do the presentation for our Washoe County proclamation, which we have right here. I don't know if you want to read it,
I'm happy
or simply
to.
just to say where you
And
are.
I should sign it as well.
There you go. We have another one signed underneath.
Okay, good.
Hello, everyone. I'm Alexis Hill, and I'm a county commissioner in Washoe County. It is a joy to serve all of you. I just came from Earth Day, which is why I'm so casual. But I actually think Earth Day and Parkinson's have parallel lines here, because my mom has Parkinson's, my grandpa had Parkinson's, both my aunts have Parkinson's, my aunt's husband who died had Parkinson's, and where did they all live? Sweeney, Texas, on an oil refinery. And I do want to talk about how important it is that we invest in communities where we have clean air, clean water. And we're so blessed to live in Washoe County, where we have incredible natural resources. And I just want to tell you, I'm thinking of all you who are experiencing Parkinson's, because my family, we experience it every day with my mom, and see her strength and how hard it is. And so I also recognize caregivers who are helping people with Parkinson's. Thank you so much for what you do. Our family receives a lot of help, and my dad has been so strong, but it's hard. And so I just want to tell you, you're not alone, and there are so many families who are dealing with this, and I just want to offer my support as your commissioner, but also someone who is a caretaker and a daughter of someone with Parkinson's, and an advocate for all the work that this organization is doing. So the Board of County Commissioners recognize Parkinson's disease affects 1 million people in the United States. This is the second most common neurodegenerative disease. It is believed to be caused by a combination of genetic and environmental factors, and is a leading cause of death, according to the U.S. Centers for Disease Control and Prevention. And whereas it is estimated that Parkinson's costs the United States $58 billion a year, of which the federal government shoulders $29 billion, leaving American families to cover the remaining estimating $29 billion every year. And whereas it's estimated by the year 2037, the number of people with Parkinson's in the U.S. will nearly double. The disease will cost Americans at least $79 billion every year. And the symptoms of Parkinson's disease can include dementia, cognitive impairment, tremors, slowness of movement, freezing in place, inability to walk and maintain balance, speech difficulties, depression, losing the ability to swallow, and a variety of other symptoms. And whereas the Michael J. Fox Foundation's Parkinson's Progression Markers Initiative works hand in hand with federal and state efforts to identify causes of Parkinson's in an effort to one day prevent Parkinson's. And whereas there are tens of millions of family, caregivers, friends, and loved ones whose lives are greatly affected by Parkinson's disease. And whereas more research and increased education, community support services are needed to find better treatments and a cure, as well as maintaining dignity for those living with the disease today. Now therefore, Washoe County Commission, Alexis Hill, does recognize this month as April Parkinson's Disease Awareness Month, dated this 18th day of April. Thank you all for coming out, and it's really exciting, this partnership between Renown and Kaiser, because I think we're going to have more specialty care in this region, and DBS surgeries will be accessible in Reno, because my mom had to go to UC Davis for hers. So I think there's some bright spots in this community, and just thinking of you all, so thank you.
With that, I would like to thank everybody.